Okay, hello, good evening. How are you and how is study? Today we will go for the second session for vascular surgery, eMRCS question bank. Let's start. Yes, I think, yes, we finished this one last time. So we will go for this one. Okay, start Dr. Doffer. Others, please mute.
Start? Okay.
Yes, you can start, yes.
A 41-year-old man is admitted with the peritonitis secondary to the perforated appendix. He is treatment with a laparoscopic appendectomy by has a stoma post-operative course. He is now developed increased abdominal pain, and he has been vomiting. Laparotomy is performed, and operation are large amount of the small bowel show evidence of patch area of infarcted. What is the most likely cause? Mesenteric venous thrombosis, superior mesenteric venous artery thrombosis, acute or chronic mesenteric ischemia, vasculitis, and the medial arcuate ligament syndrome. I suspect it is mesenteric venous thrombosis.
Okay. Anyone has different answer? Okay, yes, exactly. So I have here a source of infection inside the abdomen. And the patient may get into sepsis or intra-abdominal sepsis. That's why it's the most possible that the patient have thrombosis inside the mesenteric venous supply. Okay. Next question.
Athene, 72.
Okay,
okay.
Yes, okay.
Yes. Athene, 72-year-old lady has a 3-week history of the postprandial abdominal pain in the central located. She has episodic diarrhea and occasionally has passed blood per rectum. She has a history of ischemic heart disease and marked renal impaired from the ACE inhibitor usage. What is the most appropriate investigation? Colonoscope, duplex ultrasound, CT angio, CT scan with contrast, measurement of the fecal calprotectin. For me, I suspect it is we need to do duplex ultrasound or scan of abdomen.
Okay. Anyone has different answer? Dr. is saying CT angio. Dr. is no. Yes, A. Dr. Noran C. Okay, why Dr. Daffer you didn't choose CT angio? It is most
yes, because it's 3
more.
Yes, 3-week history, central located diarrhea, and this may be related to the ischemia of the mesenteric vein. So I choose the duplex ultrasound, but
CT angio is more accurate for this.
Yes.
Okay, so the only thing that I did say before, you have to benefit from every scenario and every word in the scenario. So there is an sentence here said she has a history of ischemic heart disease
Yes.
and marked renal impairment from ACE inhibitors. So he tells you that the patient is not candidate for any dye, for any contrast material. Here is the CT angiogram is perfect, and if he doesn't mention this word, this sentence, and he doesn't mention that she has a renal impairment, you will go for CT angio for sure, okay?
Yes.
So duplex, because the patient has a problem with contrast material. Okay, even in the answer, ideally a CT angiogram will be the best test, but with her impaired renal function and low BMI, duplex will be more reasonable. Okay, so this is very common word in the if he tried to get a new question, he can just change the scenario, but he will let's keep this. You have to put in your mind, if he mentioned renal impairment, you have to go away from CT or any contrast study, okay?
Yes.
Okay. Anyone wants to share can raise hand, please. So Dr. Daffer will continue till anyone said. Okay, Dr. Daffer, go so we can finish early.
54 years old lady presented with the recurrent right side varicose vein. She underwent endovenous laser ablation 5 years previously. On examination, she has a skin change affected the medial lower leg. Image demonstrated colonize of the long saphenous vein and saphenofemoral junction incompetence. What is the most appropriate option? Offer redo endovenous laser therapy, offer fume sclerotherapy, offer sclerotherapy disconnection of the long saphenous strip above the knee and avulsion or requirement, offer saphenofemoral disconnection, long saphenous strip to below the knee avulsion as required, offer saphenofemoral junction ligation alone. I choose the C.
Okay, why did you choose C?
It is redo. It is failure of laser ablation, so I will need to remove the all and avulsion above the knee to avoid injury to the nerve.
Perfect. I just noticed from the UK policy and Royal College policy in England that they don't like to make strapping below the knee. Okay, all strappings are done just above the knee with avulsion at well, and they found that it gives the same result with less complications than complete avulsion till the ankle or till below the knee. Okay, so that's right. Saphenofemoral disconnection. So you will not suspect the patient or make the patient do again laser, because many failure, even on my personal experience, that I know many patients that went for laser ablation and they get recurrence again because recanalization of the vein happens. So they go direct for the surgical solution. Next question.
An 83 years old lady is admitted for nursing home with infected lower leg ulcer. She underwent attempt of the long superficial femoral artery intimal angioplasty 2 weeks previously. They demonstrate poor run of below the knee. What is the best course of action? Below knee amputation with the burger flaps, below knee amputation with the skewy flap, a transfemoral amputation, gritty stock amputation, and wound debridements.
This is a superficial femoral artery.
Superficial femoral artery, yes.
Yes, block. Okay. And she went for an angioplasty for this superficial. He wants to tell you that she had problem in the occlusion is in the superficial femoral.
Yes.
Okay, and she went for angio with failed angio because there is no distal runoff. Putting in mind that the patient is coming from a nursing home with infected leg ulcers,
Yes.
and she is 83. What you see the most beneficial solution for this patient?
For me, transfemoral, no, it's 83 years old. So for that, I would choose transfemoral amputation. But it is too old and it's not. I don't know about this.
Okay, anyone can give the answer? Okay, let's make it simple. There is occlusion in superficial femoral artery with no distal runoff. What's your surgical option for her? You answered right in chat. I think no, wrong. Okay. Femoral occlusion. Yes, exactly. Femoral occlusion is above knee amputation.
Yes.
Above knee amputation because the popliteal, no distal runoff means that the popliteal is occluded. Okay, so
yeah.
when I do below knee, when the popliteal is intact.
Yes.
But I want to do above knee amputation. We just wanted to confuse you by transfemoral amputation.
Yes.
Great stocks the same. We don't do it in this patient, and she's coming from a nursing home, and it's really so above knee amputation is the best solution. So you get rid of the infected ulcers,
Yes.
and you make an amputation for the level. So superficial femoral, we do, or popliteal occlusion, we do above knee.
Yes.
Because if you did below knee in popliteal occlusion, there is a very high risk that you may have to redo operation for higher amputation. So most people go for above knee amputation.
Yes.
Okay, which is called the same transfemoral amputation. Okay.
Okay.
Clear?
Yes, it's clear.
Okay, next question.
32 years old male is noted to have a tender mass in the right groin area. There are also red streak of the thigh extended from the small abrasion. What is the most likely explanation? Lymphogenitis, saphenous varices, femoral artery neurism, abscess, and calcinated hernia. I suspect it is A, lymphadenitis.
Exactly. Why? What is this red streaks?
It is, I don't know, red streak on the thigh. It is maybe Klippel.
No.
No?
You said it.
Yes.
You said it with your answer.
Lymphogenitis.
Lymphangites, exactly. This lymphangites.
Yes.
This is the streaks on the side extending from the small abrasion. Okay, so this is lymphangites and caused an inguinal lymphadenitis.
Yes.
Okay, so just tender mass, saphenous varix is not tender, femoral artery aneurysm is not tender, abscess Yes, maybe. But why he mentioned a wound or abrasion wound with streaks? So he need to tell me there is something not abscess. So it is secondary to another thing. Incarcerated hernia will go with different scenario. Okay.
Yes.
Dr. Abul Yazid wants to share.
Yes.
Okay, you can go. I mute. Or you want to ask? Okay, I'll unmute you. Unmute yourself, Dr. Muhammad Abul Yazid. Unmute yourself if you want to ask. Okay, Dr. Dhafar, you can go.
Yes. Okay.
You can write in chat if you want to tell me something. Okay, go.
Which of the ankle brachial pressure index measures shown below is the most likely to be found in the 45 years old man who developed a calf pain after walking 600 yards if resolved during the period of the rest, more than 1.2, 1.7, 5, 0.3. I suspect it is 0.7 C, because
Yes.
one, it is more than in the rheumatic arthritis will diabetic, atherosclerotic. One, it's normal. I mean, from the 8 to, from the 5.5 to 5, it is intermittent, like the with the mobility, it is moderate stenosis. So it's 0.7.
Perfect, exactly. 0.3 and 0.5, this is in severe cases. 0.3 actually it is a critical limb ischemia, 0.5 severe. 0.7 it's mild or moderate, like 600 yards, and 1.2 it's almost normal. Okay.
Yeah.
The same here, we can't remember. From 1 to 1.2 it is normal. 0.8 to 1 it is minor. Just treatment will be just modification of lifestyle. 0.5 to 0.8 like moderate, and he needs some investigation for clearance. 0.3 or to 0.5 it is severe, and less than 0.3 or 0.3 is a critical limb ischemia. Okay, next question.
A 78 years old developed sudden onset abdominal pain and almost immediately afterward passing a large amount of diarrhea. What is the most appropriate investigation? Abdominal X-ray, CT scan, abdominal MRI, abdominal ultrasound, rigid sigmoidoscope. It is the sudden onset abdominal pain or immediately past large amount. It's CT angio.
Exactly. Here he didn't mention anything about renal function.
Yeah.
So you can go for like abdominal ultrasound, because sometimes they do duplex with abdominal ultrasound, but CT angio is the gold standard investigation for mesenteric vascular occlusion. Okay, exactly. CT angio is the best choice. Next question.
A 66 years old referred via aneurysm screen program with abdominal aortic aneurysm measured 4x4 cm. Apart from well-controlled type 2 diabetes mellitus, he has no other comorbid. What is the best course of action? Acute abdominal aneurysm repair during the next 42 hours. It's not. Ultrasound the 6 month, CT angio, and MRI aortic angiogram. Discharge from the program. I will go with the follow-up. It should be follow-up for this patient with the CT aortic angiogram.
You choose C.
Yeah.
So this patient is old age.
Yeah.
Screening program say
The size of aneurysm is 4/4.
4.4.
Yeah.
Yes, controlled, has no risk factors or no comorbidities. Okay, in vascular surgery, you are doing CT angio prior to surgical intervention. Okay, only on planning for surgical intervention, or you have a high chance for planning for surgical intervention, you will do CT angio. Otherwise, you are doing simple investigations like abdominal ultrasound. Okay, 4.4, is he amenable for surgery?
No.
And he already did the aortic ultrasound in the screening program. Okay, so our answer is ultrasound in 6 minutes. Okay, let's agree for this. More than 5 or sometimes 5.5, you will go for CT angio because, or aortic angio because you are planning for surgery. Less than 5, or sometimes he will not give you the borderline, it's 5, he will tell you 4 or 4.5. So you are going with 2 options. If the patient is asymptomatic and healthy, you will go for follow-up every 6 months. If the patient is symptomatic, according to the degree of morbidity and the comorbidities for the patient, you may make it every 3 months, or you can go for, even if it is 4 or 4.5 and symptomatic, or patient has many comorbidities. So you will go for CT angio and the plan for surgery. So more than 5, you will plan for surgery. Less than 5, you will go for any of the 2 scenarios, even conservative if the patient healthy and have no comorbidities, or you go for CT angio and surgery if the patient is symptomatic and have many or some comorbidities. Okay, and he just mentioned here the patient has controlled diabetes and no other comorbidities. Okay?
Okay.
Clear?
Yes, it's clear.
Next question.
Yes. 78 years old, presented with the left side rest pain in the leg and non-healing arterial leg ulcer. On the same leg image show normal right leg vessels. On the left side, there is the long occlusion of the external iliac artery that is unsuitable for stenting. Has a significant cardiac history. What is the most appropriate treatment option? Aorto bifemoral bypass, axillo bifemoral bypass, femoral crossover graft, femorodistal bypass, and amputation. There is no healing ulcer. هنا side pain. I thinking about aorto, just one occlusion. I don't know.
Okay, let's think here. The patient is unsuitable for stenting, so he will be amenable for which surgery?
So amputation.
Bypass surgery. Why
Bypass.
amputation? It
Yes,
is
yes.
closure in the iliac, external
Yes.
iliac. Okay, so you want to do hip disarticulation. and this is the occlusion. So he didn't tell you that this is long occlusion. Just he said this occlusion in the external iliac, but can't be stented. And then it is not the superficial femoral or the femoral artery is not occluded. Okay.
Yes.
So we agree that this patient need a bypass surgery. We said short occlusion, we will go for angio.
Yes.
Long occlusion, we will go for bypass. Okay.
Yes.
Let's think together. Okay. So we have two types of bypass. Okay.
Yes.
So this patient has okay, let's do it simple like this. Okay, this patient have occlusion in the external iliac. This is internal, and this is external iliac. And then go for femoral. Okay. I have occlusion here in the external iliac, and I need to do a bypass surgery. So I have two options for bypass. I have this bypass, what's called aortofemoral bypass. Okay.
Yes.
And this is a major surgery. And I have, this is what's called anatomical. Anatomical, I have two options, anatomical and extra anatomical.
Yes.
Anatomical, I have only this aortofemoral bypass graft. Okay. Extra anatomical, I have two options. I have, this is the upper limb axillary. Extra anatomical, I have two options. I have what is called axillofemoral bypass, right?
Okay.
Axillofemoral bypass. But I can't find here axillofemoral
Yes.
bypass. I just find axillobifemoral, and the other femoral is patent.
Yes.
So he mentioned the other femoral is patent. So what he needs from me is femoral bypass. This is the two extra anatomical options. Why I choose extra anatomical? The patient has a significant cardiac history.
Yes.
So he told me this patient is unsuitable for anatomical bypass. So you have to choose extra anatomical bypass. So what's your extra anatomical bypass? I have axillofemoral and I have femorofemoral bypass. Because he mentioned that the other leg is patent femoral artery. Okay, so that's what we are searching for.
Okay.
Clear?
It's clear now.
Femorofemoral bypasses. I have some comments here. Okay, so is it clear? Anyone wants to ask about anything, or it is not clear? Because we just discussed that last session. Anyone new and want to clear it can raise hand, please. Is this issue clear or not clear?
It's clear for me now.
Clear now. Okay. We will have many questions like this. Okay. We will face many other answers. So we will be more clear in the next question. So I need more to share. Like I cannot choose Dr. Ahmed Aweda, Dr. Basharat, Dr. Az, Dr. Nuran. One wants to share a It's easy. Dr. Basharat, okay. Go. Want Dr. Duffer to just have break. Unmute yourself.
Assalamu alaikum.
Alaikum salam.
Alaikum salam, Dr. Talal.
A 52 years old. Okay.
Okay, Dr. Basharat, the next one, okay?
Okay, sir. Okay.
Okay,
I will start.
Okay, Dr. Talal start, as in Dr. Basharat.
Okay. 52 years old lady developed a lower limb swelling. Radiovascular vein surgery. There's an evidence of swelling of the left leg up to the knee. The overlying skin appears healthy. What is the best management option? Hormones operation, multiplier compression badges, high dose furosemide, high dose bumetanide, lymphovenous anastomosis. Okay. I don't know, sorry.
Okay, anyone have answer?
I will go for the Homans operation. Actually, there are 3 operations in the lymphadenitis. One is Homans, one is Charles, and another last one is the lymphovenous anastomosis. If the overlying skin is healthy,
Okay.
so we can go for Homans operation because the skin is used as a graft.
This operation, okay.
Homans
This operation's for what? For what?
This operation is remove the swelling of the caused by the lymphadenitis,
For what
fluid
disease?
filled tissue. For lymphadenitis.
For what disease?
For lymphoedema.
Not for lymphadenitis. For
lymphedema.
lymphedema. Is this case of lymphedema? This is for chronic lymphedema.
Yes.
Chronic lymphedema. Clear that this operation is for chronic lymphedema.
Yes.
Is this a case of chronic lymphedema?
Yes.
This is chronic. Patient after post-redo varicose vein surgery developed swelling of the leg up to the knee, and the overlying skin is
acute.
healthy. What is the best? Acute, exactly. So
This is
what I need.
multi-layer compression bandage.
Exactly.
Multi-layer compression bandage.
Exactly. If anyone vascular surgeon and he've done, it is a very common to put a bandage for 2 weeks for any, not even redo, vascular stripping or vascular varicose vein surgery. Okay, it is very, very common to do, and it's one of the post-operative protocols. You have to put compression bandage, compression stocking for 2 weeks post-operative, and to be removed slowly. Okay,
Yes.
so this is something
Yes.
from protocols of the treatment of acute lymphedema, because you just remove the veins and you make triple ligation and you make devascularization of the venous drainage, and the normal body water will go through the lymphatics. So you will have a temporary lymph, I can say like
Edema.
crowded fluid edema through the lymphatics that doesn't use for this amount of fluid until lymphogenesis happen and the start lymphatic visit to be more wider to accept more fluid afterward. Okay, so what I'll do in this patient, just multiple compression bandage. What about what you said for, let's clear that also. You said we have three operations for chronic lymphedema. Okay?
Yes.
Yes.
Exactly. We have what's called Homans.
Homans, Charles, and
We have
lymphovenous anastomosis.
Charles.
Charlie's.
and lymphovenous anastomosis. What is the difference between the three?
In the homens, the skin should be healthy, and the skin it is preserved for an overlying skin flap. In the Charlie's, all skin and the subcutaneous tissue around the cough is excised down to the deep fascia.
Okay. Okay.
And in the lymphovenous anastomosis, there are the lymphatic veins are anastomosed with the subdermal venules.
Okay, so simply, homens is for just removal of
subcutaneous tissue.
Subcutaneous tissue. Okay.
Yes.
Charles.
For remove skin and subcutaneous tissue.
Exactly. Skin plus subcutaneous. This is unhealthy skin. Unhealthy skin. Okay. The last one is lymphovenous anastomosis. And this is
creation of
okay. He have to mention in the scenario. Here is in the scenario will mention skin is healthy.
Yes.
Here is will be skin unhealthy, and here is will mention that the patient have obstruction at the site of lymphadenectomy, but he will have distal intact lymphatic vessels by
and proximal obstructed.
Proximal distal or patent way for the lymphatic vessels, so you have patent vessels. Okay.
Yes.
So don't confuse between homens and the Charles. Homens, you can just make it. I was just remembering it by humanity operation. Just I remove the subcutaneous tissue. Okay, I make it like it is. I have this one, and this is the bone. And for a human operation, I'll only remove the subcutaneous. Okay, I'll only remove the subcutaneous. But Charles, like something not good, I remove the skin and subcutaneous. So humans, like human operation or humanity operation, I'll just remove subcutaneous, and Charles, something that like Charles angles. So I remove the skin and subcutaneous tissue. And lymphovascular anastomosis, the scenario will be clear. You have patent lymphatic vessel distal or proximal to the angio. Okay, next one, Dr. Basharat. Clear or someone can't understand?
Yes, sir.
So it is for chronic lymphogenitis. Okay, so Dr. Basharat, go.
A 67-year-old patient is due to undergo a femoropopliteal bypass graft. Which heparin regime should the surgeon ask for prior to cross-clamping the femoral artery? A, single therapeutic dose of low molecular weight heparin on the ward prior to coming to theater. B, single therapeutic dose of low molecular weight heparin right before surgery. C, dose of 10,000 units of unfractionated heparin prior to induction of anesthesia. D, dose of 3,000 units of unfractionated heparin 3 minutes prior to cross-clamping. And E, dose of 30,000 units of unfractionated heparin 3 minutes prior to cross-clamping. I will go for D because before cross-clamping, we give 3,000 units of unfractionated heparin to prevent thrombus formation.
Perfect. Just keep in mind, this is only the two scenarios that you will have. Even it is in practical vascular surgery, I have worked it for some time. It is just a routine to give 3,000 before any grafts, any vessel graft, any vessel bypass. They just give the 3,000 units 5 minutes or 3 minutes before cross clamping. And in cardiac surgery, they give 30,000 units.
30,000.
Perfect. So yes, they give 30,000 before cardiac and 3,000 before normal any other vessel bypass. Just keep these two parameters in your mind, and nothing more is required from you. Nothing more. And these are only two questions that you will face in your exam. Okay? Don't go deep more than this.
Yes, sir.
Next question.
An 18-year-old lady presented with excessive varicose veins of her left leg. There is associated port wine staining. What is the most likely diagnosis? A, type 1 diabetes. B, Osler syndrome. C, Gardner's syndrome. D, Porteous syndrome. And E is Klippel-Trenaunay-Weber syndrome. And the answer is the last one, KTW syndrome.
Okay. And this is an easy question. You don't need to know anything more. This is keywords: young, varicose vein, what's called Klippel-Trenaunay vein, which is lateral to the leg. The saphenous vein is medial.
Yes.
On the leg. The Klippel-Trenaunay vein is lateral from the foot till the gluteus. Okay, and port wine staining. 3 landmarks give you this answer. No more. Okay?
Okay.
Nothing is required from you than this. Next question. Okay, we can
which
use
operation?
Dr. Dr. Bashrat, then we will change again Dr. Dafir.
Yes.
And anyone want
Okay,
to
sir.
share?
Which operation below is an amputation of the lower limb in which the femoral condyles are removed and the patella retained? A, transfemoral amputation. B, gritty strokes amputation. C, Sims amputation. D, below knee amputation with the Burgess flap. And E, below knee amputation with the skew flap. I will go for the B as gritty stroke amputation because it's a through knee amputation and the patella is brought backwards. All the other operations are below knee, and
Perfect.
So I will go with B.
What is Sims amputation? Sims amputation.
Sims amputation is the ankle, is the through ankle amputation.
Exactly.
Actually, we have to. Actually, we have to remind here three or four amputations. One is hind quarter amputation, which is through the this is a transfemoral this one. Sorry.
This is disarticulation of the hip.
Disarticulation
of the hip.
Yes.
Yeah, but just
disarticulation of that. Then there is gritty strokes amputation. It is through the knee, and the Sims amputation is through the ankle.
Okay, exactly. Next question, Dr. Dafir.
Yes. 66-year-old man has been suffering from the weight loss and development severe abdominal pain. He is admitted to the hospital and undergo laparotomy, operation entirely small bowel infarction, and only the left colon is viable. What is the most likely explanation? Mesenteric venous thrombosis, acute on chronic mesenteric ischemia, acute ampuli of inferior mesenteric artery, acute ampuli infected the celiac axis, adequate ligament compression syndrome. So it is the weight loss, it is the old, so mesenteric venous thrombosis. I choose the one. A. Acute on chronic, yes.
So what's your answer?
So according to that, the acute on chronic.
Okay, from the scenario,
Yes.
weight loss is a long history,
Chronic, yes.
chronic. So it is a chronic problem for a long time. So he lost weight, develops acute, so something acute on top of it. Okay, and he make an operation. So infarction means arterial, then left colon only. So what supplies the left colon is the inferior mesenteric.
Yes.
And what
Inferior
supplies
mesenteric.
the other? What supplies the other
Superior
part of the
mesenteric.
intestine and colon? Superior mesenteric.
Superior
So
mesenteric.
let's search here. So this is acute on top of chronic. So it will be B. So why it is not inferior mesenteric? Acute embolus of inferior mesenteric. No, the left colon is intact. Acute imbalance affecting celiac axis. So celiac axis doesn't supply the colon. Acute arcuate ligament compression syndrome. This is something like chronic. It will not go with acute, just will go with post, what is called, we talk about, this is postprandial ischemia. You remember this scenario? A patient suffering from postprandial abdominal pain because of the arcuate ligament compression syndrome, which inhibits the GIT to increase its blood supply after food. So this is what's called for this one for postprandial abdominal pain or what's called abdominal angina. Okay, this is abdominal angina. Arcuate ligament compression syndrome, put it in your mind, what's called postprandial abdominal pain or abdominal angina. So clear. And mesenteric venous thrombosis. So it is not a venous problem, it is an arterial problem.
Arterial.
Get the answer clear?
Yes.
Clear for all? Anyone wants to ask? Okay, so no one raise hand, so it's clear. So next one, okay, Dr. Basharat and Dr. Dafar, everyone take one question. So next is Dr. Basharat, and if anyone wants to share can raise hand, please. Okay, go.
Okay. Which of the interventions listed below would be conventional treatment for a venous ulcer? Compression bandage, limb elevation to control edema, optimization of glycemic control of diabetic, use of skin graft in selected cases, excision and closure in selected cases.
Not, okay, not. So,
conventional, it is asking about not be a conventional treatment. So
it's okay. Limb elevation is okay. Optimize glycemic, no. Use of graft,
excision and closure is the selected cases.
Exactly. In this question, when he wants you to tell
Yes, excision and
one
closure.
of the following, just think, when you have a question saying which of the following is true about, or which of the following is right about, during your reading, say is it yes or not, and just put in your mind, or just put a small mark with your pencil, okay? So it will be easy for you not to confuse. So you have a patient with venous ulcer. So the patient has chronic venous insufficiency, compression bandage, very common, we do it. Lymph elevation to decrease the venous pressure, yes, we do it. Lifestyle modification like glycemic control, blood pressure control, antiplatelet, and sometimes we give like blood thinners, yes. Use a skin graft. Sometimes with a big ulcer we use a skin fresh graft, but we didn't say before, we didn't see that you make excision and closure. It is something like I didn't see before. Okay, so this is the right answer.
Heal. It is not.
Yes, it will not heal if the stitches will not heal. Okay, next question. Dr. Ibrahim wants to share. Unmute yourself. Okay, Dr. Ibrahim. Dr. Ibrahim want to share? Unmute yourself.
Yeah, no. Hello?
Yes, okay.
You heard me now?
Yes, start.
Okay. 23 years old man present with intermittent symptoms of altered sensation in his arm and discomfort when he uses his hand. He works as electrician and has his symptoms and worried when he's fitting light fixture. What's the most likely cause? Cervical rib, axillary artery embolism, axillary vein thrombosis, raynaud's, atheroma of subclavian artery. I think it's A, cervical rib.
Exactly. So other options. Other option is non-logic. Please. Okay, so yes, exactly.
Yeah.
Cervical rib is the right answer. So the patient have some neurological symptoms, and he was like working like electrician, so he uses his arm, and sometimes to the ceiling his arm is up, and this is one of the tests for testing the cervical rib. You know, anyone know what is Addison's test? Exactly. I was just going to ask about
actually the head is tilted towards the non-symptomatic side, and the arm is extended, and the symptomatic side arm is extended.
Yeah, it is just elevated, abducted till a level.
Yes.
The patient feels some compression in the arm. Okay, so Addison's test is the test for cervical rib. Thrombosis or embolus, nothing in the scenario that can give us the patient intermittent symptoms. So it is not an embolus, it is not thrombosis. Raynaud's. What's Raynaud's?
Raynaud's is cyanosis.
Vasculitis of
It's just a minute. For the test for obstruction, it is a Rose test. You said abduction and external rotation. It is the Rose test. Addison test, flexion of the head and traction of the limb. Yeah.
Sorry, again. Yeah.
Hello. The Addison's test actually is lateral flexation of the neck away from the symptomatic side, and the traction of the symptomatic arm leads to the obliteration of the radial pulse.
Exactly. Yes. Okay. So, what is Raynaud's?
Raynaud's, there will be discoloration of the arm, coloration of the arm, and there will be history of smoking.
Oh, it's not related to smoking.
No, it's, burger is related to smoking. Burger disease.
What is the difference
There will be
between
discoloration.
Renal phenomena
what is the
is
difference
related
between
more in females than males, and it's related to cold weather, and it appears in the peripheral extremities.
okay, so what is the main the core difference between Raynaud's and Berger's?
One veins and one arteries.
No, both arteries.
Both arteries.
Yes. No, I just want to know the pathology of Raynaud's and the pathology of
Raynaud's
Berger.
is vasoconstriction. Raynaud's is vasoconstriction.
Vasospastic, it is a vasospastic disease.
Yes.
Hypersympathetic activity. It is not vasculitis because I think Dr. Daffer or Dr. Basharat say it is vasculitis. It is not a sort of vasculitis. It is vasospastic disease, and sometimes we treat it by sympathectomy. Okay, that's sometimes they inject something like Botox in the hand so they can stop the activity of the sympathetic. And Berger is a sort of vasculitis, chronic vasculitis because of smoking.
Yes.
Okay, so this is vasculitis associated with smoking. In men, Raynaud's is vasospastic disease associated with sympathetic hyperactivity, and it's much more common in females. So you'll find a young lady or a young girl suffering from this. So it is Raynaud's, and this is one of the key points in the or keywords in the question in the scenario, that a female, young age, and have something discoloration increased by cold weather and decreased by hot water or something like this. Okay. Next question.
Yes, thank you. I had confusion between Burgess and Raynaud.
Okay, it's clear, or anyone wants to know?
Can I continue?
No, thank you.
Okay, Dr. Ibrahim, take another question, then Dr. Daffer, then Dr. Basharat. So you can go, Dr. Ibrahim, Dr. Daffer, Dr. Basharat.
Okay.
Anyone wants to share more? Can. Okay.
During short softness vein surgery of varicose vein, which of the following nerves is particularly at risk? Shoulder nerve, popliteal nerve, tibial, femoral, and softness.
It's from anatomy?
Yeah, it's anatomy. But short softness, shoulder nerve. Long softness, softness nerve. This for injury of the nerve.
Okay. This is today, this is from the records of September 2019, by the way. Okay, sure enough. Next question, Dr. Daffer.
20 years old intravenous drug users is found to have femoral abscess and needs to contact the on-call doctor and the patient temperature of 39 centigrade. He is found to have a pansystolic murmur louding at the left sternal edge at the fourth intercostal space, and the most likely lesion, aortic regurg, mitral regurg, aortic stenosis, tricuspid stenosis, so tricuspid regurg. It is tricuspid, okay. Pansystolic, it is tricuspid regurg.
Why? Why not stenosis?
Just a minute, pansystolic. Tricuspid stenosis, yes. It's tricuspid stenosis.
No, I'm asking, you were right, don't doubt.
Yes,
I'm just asking, why not?
Yes, because it is a pansystolic with the sites for the fourth intercostal space. So it's tricuspid regurg.
Okay, exactly, tricuspid regurg. What is about this issue? Is it clear, or you want me to simplify again in a few minutes?
For me, it's clear.
Anyone, it is not clear, can write in chat, please. Okay, Dr. Fatima wants to explain. So So, okay, because someone wants to, okay, Dr. Ajaye also. Okay, I'll make it simple again with a very diagram, small diagram like this. Okay, this is the ventricle, which will make the systole, and I have two vessels, one like big and one like small. So let's imagine this will be this will be the aortic or the pulmonary, and this will be let's make it with a different color. This will be the mitral or tricuspid. Normal, I have blood coming here and then blood go here. Okay, clear. I'll open mic for all, so anyone just can't understand, but anyone just have noise background can just mute himself, please. Okay, and so blood coming from here and go from here. Let's go. If he telling me there is a systole, systolic, so normal in the systole, okay, in the systole, when happening systole, the normal blood go, this is closed, and here go. If I have a murmur here during the way of the blood, during systole, so there is something here not open good, so this is stenosis. Stenosis. So if I hear during systole on the aortic or pulmonary in the second left intercostal space during systole, and I hear a murmur, so normally the blood passes through the aortic or through the pulmonary, and I hear a murmur, so it is most commonly a stenosis. Clear? If I hear a murmur on the fifth intercostal space or the fourth intercostal space on the left, what's mean on the aortic or tricuspid area, and during systole, normally I should hear no murmur. But if I hear a murmur here, so there is some blood coming back. So it is a regurg. Clear? Or again? Clear?
Yeah, clear, doctor.
Here during systole, stenosis. Here during systole, regurg. On the diastole will be the reverse. During diastole, normally blood passing here and here is closed. So if I hear during diastole here, I hear a
Regurg.
murmur on the normally closed, so it is regurg. And if I hear here a murmur, and I should hear soft sound, and if I hear a murmur, so it is stenosis. Because this is a normal pathway, so it is stenosis. On the abnormal pathway will be regurg. I can't clear more than that. If anyone can't understand, just know it like this. This is what's we are almost always asked about the aortic and mitral, regurg, and aortic regurg, and mitral stenosis. We almost always ask about a mitral and mitral and aortic, most common. Mitral
Can
and
we read the
aortic.
question again, please? Can we read the question back again?
Okay, again. Here is this nursing staff here. So, okay, history of operation. He found a pansystolic murmur. Okay, pansystolic. Let's go. Where is it? Left sternal angle force intercostal space. So it is on the tricuspid area. This is systole. Normally, tricuspid should be closed. Normally, should be closed. And it shouldn't pass any blood. But I can hear a murmur, so there is some defect, there is some regurg happened in it. But if he told us a pansystolic murmur in the second right intercostal space. So what will it be?
Aortic stenosis?
Aortic stenosis or tricuspid.
Aortic
or
stenosis,
pulmonary.
exactly. Aortic stenosis. I'm searching. Let's so here is the force. So go in the question for the tricuspid. And all this is wrong. Okay? Make it easy.
Okay.
He will give you the space, and by the
Yes.
space you can exclude 2 or you will exclude 3 because you have for every valve you have to even regurg or stenosis. So by the space you will cancel 3 answer. Then we have tricuspid. Let's go. This is systolic. If the systolic go from the small valve, it will be stenosis. From the big valve, it will be
Regurg.
regurg.
Now
Just
clear.
can you solve it by exclusion? Okay.
Yeah. Thank you.
Okay. Okay, exactly, Dr. Muhammad. Drug. He says drug addiction is related to tricuspid as well. Okay, next question. Who's third?
A 21-year-old badminton player attended accident and emergency with a painful swollen right arm. He is right-handed. Clinically, he has dusky fingers and his upper limb pulses are present. An axillary vein thrombosis is confirmed. What is the best acute treatment to achieve vein patency? Intravenous heparin, B warfarin, catheter-directed TPA, low molecular weight heparin, and aspirin. C, catheter-directed TPA.
Exactly. So he is asking about what is the acute treatment to achieve vein patency. He wants you to make a vein patency just now. Low molecular weight heparin, no. Aspirin, no. Warfarin, no. Intravenous heparin, also no. The only thing that will give you an acute patency is the catheter-directed TPA. Okay, next question.
I can read if you want, Doctor.
Who's Dr. Az?
Yes.
Okay, Dr. Az, go.
A 23-year-old man presented with a brachial artery embolus. The cervical rib is suspected as being the underlying cause. From which of the following vertebral level do they most often arise? C7, C5, C4, C3, C2. I think C7.
Exactly, cervical lip coming from C7.
The elongation of transverse processes of C7.
Exactly.
Yes, sometimes it is a fibrous band, by the way. It is not a bone. It is not elongation. Sometimes just a fibrous band.
Yes, it starts from the processes, but it does not reach the sternum.
Exactly.
Yes. Like floating ribs. Yeah.
Yes. Okay, next. Oh.
A 57-year-old lady has suffered from lymphedema for many years. The left leg is swollen to the mid-thigh. Severe limb deformity has developed as a result of process and in spite of compression hosiery. Lymphoscintigraphy shows no patent lymphatings in the proximal leg. The overlying skin is healthy. Which of the following options would give the best long-term outcome? Multi-layer compression bands. The question we talked about. This chronic lymphedema. Yes. Homan's operation. Multi-layer compression bandage. Charles operation. Homan's operation. Long-term loop diuretic therapy. Amputation. I think this humans operation is called Homan's operation because the overlying skin is healthy. If it's not healthy, we go to Charles operation, subcutaneous and skin. No hormones? No operation?
Okay, I just put a line. I put a line about chronic lymphedema. Okay, and I put about patent lymphatics in the proximal leg.
No patent.
By the way, this patent. No patent lymphatics.
No patent. No
patent lymphatic overlying. Which of the? Sorry. Okay, so it's my fault. Yes. So the overlying skin is healthy. So what is operation?
Hormones.
Hormones. Okay. Yes. I apologize. I apologize. Sorry, I'm sorry for this. By the way, I don't know the answers. Most answers I don't know, and sometimes I know because, and sometimes I just guess. But I just read shows patent lymphatics. That's why I went to. Even in here is not the lymphogenesis. Lymphovenous anastomosis is not here even, so I didn't even read the answers. Okay, sorry again, Dr. Ahmed. So you go for the next one.
It's okay. Okay. I think it's the first question I answered right now.
No. You are perfect. Don't.
Yeah, we are sharing our knowledge.
Yes, exactly.
Yes, exactly.
Okay, Dr. S, go for another one again.
Okay, a 73-year-old man with breast pain and ulceration of the foot undergoes a femorodistal bypass graft with a BTFE graft. At the end of the procedure, there are good distal foot pulses and a warm pink foot. Over the ensuing 6 days, the foot becomes progressively cooler and the pulses diminish. What is the most likely underlying explanation for this process? Impulse, new intimal flap, new intimal hyperplasia, polyarthritis, Steele syndrome. I think يعني حصل relapse again حصل like graft. Actually, I don't know.
Okay. It's normal.
The most common side effects is polytetrafluoroethylene graft. New intimal hyperplasia.
Yes, exactly. This is a very common. A very common complication with the PTFE graft that happens. A new intimal hyperplasia. By the way, this is a very common question in the exam. New intimal hyperplasia, and you have nothing to confuse with. Patient went for femorodistal graft with PTFE followed by occlusion, and the what is the cause? It's the new intimal hyperplasia. How they solve this problem now?
They solved by Miller cuff surgery. They use polytetrafluoroethylene graft with the artery or the vessel. So a proximal end is polytetrafluoroethylene, and the distal end is the vein or the artery, which prevents new intimal hyperplasia.
Exactly. Now, what they do, they have the artery and they have the graft. Before, they went for a full complete graft. That's why the new intimal hyperplasia happened. And now they put what is called Miller cuff, which means the proximal part is the vessel, or mostly is a vein, and anastomosed with the polyethylene gap. So he will start with venous part, followed by the PTFE graft. This is called Miller cuff. Okay, this is one Miller cuff. When PTFE graft is bypass conduit. Okay, so that's why he can get rid of or decrease the incidence of new intimal hyperplasia by the PT or by the Miller cuff graft. Okay, clear? That's all what is required from you. Don't go what is Miller cuff and how we do it and what vein is used and when to do it and not when to do it. You have two questions. Sometimes ask about it, so it is the Miller cuff, and if doesn't ask about it, so he will ask about what is the problem of the graft after we did, is the new intimal hyperplasia. Nothing is required from you more than this, okay? Don't go deep more than this. Yeah, next question. I need new one. Again with Dr. Dafer and Dr. Basharat. Dr. Dafer, go.
Okay. Which of the following is not typical feature of chronic venous leg ulcer? Hip raised border of the ulcer has been present more than 5 years. Evidence of surrounding lipomyelosclerosis, irregular shape to the ulcer. 20% of the case have previous history of venous thrombosis, hemosiderin deposit in the surrounding skin. Hipped up goes with the A. Hip raised border, it is marginal ulcer.
Exactly.
Yes.
All other lipodermatous sclerosis is very common. Irregular shape of the ulcer is common. Mostly, many of them have history of deep venous thrombosis, so it is secondary varicose vein. Hemosiderin deposit is the main cause for the lipodermatous sclerosis. So, and to go for a cancer after 5 years, I think it's more than 15 years to get a cancer.
Yes.
Okay. I can just remember, I have read it before. It makes more than 15 years for a venous ulcer to become cancerous. Okay, next question, Dr. Basharat.
A 74-year-old man presented with a painful right leg. The pain developed suddenly the preceding evening. However, he wondered if it might resolve overnight. Instead, it had gone worse. On examination, his right leg is cold and white with diminished distal sensation. The CT angiogram shows a thrombus occluding the external iliac artery with no atheromatous diseases. What is the most appropriate course of action? Femoral embolectomy and below knee fasciotomy. Seg B, femoral embolectomy alone. Femoral popliteal bypass graft without fasciotomy. Femoral embolectomy with above and below knee fasciotomy. And the last one, femoral crossover graft with above and below knee fasciotomy. Yes, there is a history. There is a compartment syndrome, so we have definitely go with a fasciotomy. It is.
It's not compartment syndrome.
No, it can further lead to when you will recannulate it. It will lead to a compartment syndrome. It is not a compartment syndrome now.
No, it will not lead. It will lead for reperfusion injury.
Yes.
I think C. Without fasciotomy.
That's for sure.
I write here.
I goes with the fasciotomy, below knee fasciotomy.
More than 6 hours. We just said on the start of our discussion. Okay. Embolectomy plus fasciotomy. We just discussed yesterday with Dr. Dafer and Dr. Basharat and Dr.
Yes.
Ahmad Dawaid. I think so. We said that if it is more than 6 hours, we will go for fasciotomy for fear of reperfusion injury. Okay. And embolectomy because it is right leg cold and white with diminished distal sensation. This is not signs of or symptoms of compartment. This is symptoms of acute lymph ischemia. 6P, pain, paresthesia, pulseless, painful. Okay.
Yes.
Yes.
So this is the 4P, sorry. So this is a critical lymph. So I have to go for embolectomy. I don't know to go for graft. So 2 grafts, graft, no. So I have 3 options. So no graft, no graft, no graft. And I have 3 options, this and this and this. Not embolectomy alone. I have to do fasciotomy. And it is very rare to do fasciotomy above the knee. Okay, we almost always we didn't see a case with fasciotomy above the knee. We always do it because the leg is a closed compartment. By the way, through your eMRCS in part A and part B, fasciotomy only will you'll find it in the arm and leg. You have some stations in part B talking about compartment syndrome in the arm. You will go fasciotomy, and on the leg you will go for fasciotomy, but nothing you'll see any in the forearm, sorry, and in the arm and side you will not see any fasciotomy. Okay, that's what we was talking yesterday. This is what we were talking yesterday about management. Here he make like less than 6 hours, more than 6 hours, or fixed modeling. And I think also he said something about fasciotomy for reperfusion injury. Fasciotomy should be considered here, should be considered in time between onset and surgery exceed 6 hours. Okay, so thank you for this information yesterday. It just was confusing or missed from me. Okay.
Okay.
Next question.
Okay.
Who's ready? Dr. Ibrahim again.
Yeah. Which of the following isn't typical feature of arterial leg ulcer? Well demarcated edges, a gray-white base with ulcer. Men are affected more than women. Painful ankle swelling. The ankle swelling is not a feature of arterial leg ulcer.
Exactly. Arterial leg ulcer is due to ischemic
Venous.
ulcer. So ischemic ulcer. So ankle swelling is a very common with venous ulcer because it is, yes, venous ulcer because it is a drainage problem. Okay, simple question. Next one. Okay, Dr. Aiz.
A 65-year-old man presented with expressive dysphagia and right-sided weakness over 4 hours. His symptoms have now completely resolved. A CT scan of his head is normal. What is the most useful investigation? Aortogram, arterial duplex scan, 24-hour cardiac tape, implantation of a reveal device, MRI brain. أنا هقول MRI brain. لا CT scan of the head is normal. هنعمل arterial duplex scan عشان نتأكد إن النك vessels patent.
تعملوا على إيه؟
على النك veins.
Carotid.
ها؟
Neck arteries. Arteries, not veins. Arterial duplex for
neck arteries.
Carotid.
أيوة neck arteries. Carotid arteries.
Okay, so you doubt here in note E. Okay, we are doubting here transient ischemic attacks that happen. The patient have something like aphasia, right-sided expressive aphasia, dysphasia with right-sided weakness. Which artery do you suspect here?
Right side weakness. Middle cerebral. Or anterior
Perfect,
cerebral
exactly.
artery.
No, middle cerebral artery.
Yeah.
The area of the brain of the attacking the Broca's area, which is responsible for the expressive aphasia, is supplied by the, this is our brain, okay? And we have two areas, one area here called vernix, okay?
Yes.
And one area here is called Broca's. This is responsible for perceptive or receptive aphasia. And this is responsible for expressive aphasia. Okay. And both of them are in the range of the middle cerebral artery. Okay, you have some weakness because the upper arm here is a little bit represented more here because the body it is represented upside down, so you can find the leg here. So the leg is here, and you can find the arm is here. So the arm will come more with the middle cerebral artery, and the other thing is the anterior cerebral will be much more here. Okay. Okay, just information put in mind because we will face it on neurosurgery. Simply also we don't need more deep, but simply we'll just know some problems or some keywords we will go for to understand or to differentiate between anterior cerebral and middle cerebral. You will find a keyword in every scenario that will give you what is the main arterial ischemia. Okay, next question, doctor. We just have about 25 questions we want to finish.
Okay.
Okay,
doctor.
Can I go?
Yeah.
Okay, go.
Which of the antebrachial measurements shown below is the most likely to be found in a 43 years old lady with a long-standing diabetes who complains of food pain? It's worse on night and during minor exercise. A more than 1, B 0.9, 3 0.3, C D 0.5, E 0.7. It's A. This long diabetes making like a calcification of the blood vessel, which make no resistance. Is A is the right.
Okay,
A.
exactly. This question will come like this, and I have read today some recalls. The question is like this: diabetic lady, food pain, worse at night. Plus some new scenarios, some new words, but he will give you the keyword. So it's more than 1.8, more than 1. Okay.
Yes.
Okay. Repeated
Also the
scenario.
renal, also the renal, it causes more than one.
Renal more. I didn't see it in recalls even, but maybe you just know it. Okay, renal may cause more than one.
Yes, diabetic and renal and calcified atherosclerosis vein, artery. Sorry.
Okay. Okay, next question, who?
A 66-year-old man is admitted with severe angina. There is a lesion of the proximal left anterior descending coronary artery. Which of the following would be more suitable conduit for bypass? Long saphenous vein, short saphenous vein, cephalic vein, internal mammillary vein, thoracoacromial vein, internal mammillary vein.
Artery.
Perfect. One of the most common artery. We have it is
Artery,
in the heart.
mammillary artery, sorry.
In the heart, they go with the artery, and they will go with one strong artery, medium-sized artery, which is the internal mammary. It's a very common graft for cardiac operation and cabbage operation. Okay. Next question. Okay, Dr. Dafer.
Yeah. 48 years old lady admitted.
84.
84. 84 years old lady is admitted with an infected diabetic foot. An X-ray show osteomyelitis of her calcaneum. She has a fixed flexion deformity of the knee, but normal pulse. What is the best course of action? Above knee amputation, below the knee, application of the 4-layer bandage, hyperbaric oxygen debridement. I go with the one above the knee because the deformity,
Okay.
to avoid the deformity, so it go above knee amputation.
Okay. In the scenario, he will tell you a diabetic lady, old age, has a fixed deformity of her knee or on a wheelchair. Both scenarios are the same above knee amputation.
Yes.
This is the most common two scenario will come on a wheelchair and has normal pulse or has, you remember yesterday scenario on
Yes.
a wheel, old lady, diabetic, or on a wheelchair and has a normal distal runoff. Here is it changed. Fixed flexion deformity and has normal pulse. Last time, normal runoff. So both of them has no problem if the limb is useless. So amputation and above knee amputation is the best solution of her. This is very nice about amputation. Put in mind. Okay. Did non-viable organ or deadly organ, which means that the organ is infected, so he can danger life, or useless dead organ. So dead non-viable or deadly or useless dead organ are the three main causes or the three main indication for amputation. Okay, Dr. Az, go.
Which of the following types of lymphedema is congenital? Meigs disease, Meigs disease, Miller's disease, lymphedema tarda, lymphedema following surgery, lymphedema due to venous insufficiency. For myself, I will do exclusion between Meigs disease and Miller's disease. And
okay. It's just confusing, yeah?
Yeah.
Okay, exactly. So Miller's disease is congenital. Miller's
Congenital,
is congenital at birth. Meigs is after 1 year. Okay, try to know it by any things that you can mind. You this is at birth. So Miller's disease. Miller's disease is at birth. Meigs disease is after the first year, and lymphedema tarda is after 35 years. Okay.
Okay.
Clear? Yes. Next question, Dr. Dafer.
Concerning proximal aortic dissection, DPK type 1 and 2, standard for type A, which statement is false. The anti-malt here is typically more than 50% of aortic circumference. It's usually treated using the endovascular approach. They have a 50% mortality in the first 2 days. Artery reconstructed may be required deep hypothermic circulatory arrest. Target systolic pressure of around 110 millimeter mercury should be obtained. I choose the 2B. It is usually treated by using endovascular approach.
Okay.
Yes.
It is usually, this is the wrong answer. This is the false, because it is used. We have 2 options for treatment, even surgical treatment or medical treatment. Let's just have a look for any one of you first time to know what is the Stanford and what is the Becky classification. Okay, I just want to start with the Becky classification. This is aortic dissection, which affects the ascending aortic arch, the ascending and the arch and the descending. Okay, this affects all the artery. The Becky class 1 affecting all the artery. The Becky class 2 ascending only. The Becky class 3 affecting the distal or the descending only. Okay, then came Stanford and said we only have 2 classification. He will say aortic root, and he make it like 2 halves and say this is the aortic root and part of the arch, and then he said type B is the descending one. Okay, treatment options, we have only 2 treatment options for them. Sorry?
Yes, either medical or surgery.
We have 2 treatment options. The ascending aorta, or the Becky 1 and Stanford A, both of them we will do what is called
Surgery.
aortic root replacement. Okay, even the Becky 1 and 2, any problem affecting the ascending aorta or the aortic root, we will go for surgery. And this is a very common question in exam: aortic root replacement. Any dissection affecting the descending aorta, we will go for medical treatment with beta blockers. Any scenario mentioned, Stanford A or the Becky 1 or 2, which is affecting the ascending aorta, this will be aortic root replacement. But any scenario mentioning Stanford B or the Becky 3, we will go for descending aorta. We'll go for beta blockers. Okay, this is beta blockers. What is the aim of beta blockers? To make the systolic blood pressure from 100 to 120 or maximum 100. Okay, clear?
Yes, clear.
Is there anything required from you other than it? Nothing, only this. You will have no more question scenario away from these scenarios: aortic root replacement or beta blockers. Why you do for surgery for aortic root? Why you don't give beta blockers like descending?
Because the pressure in the root of aorta is high. Will lead it to the
Much more important. What else is more important?
Rupture.
Descending can rupture as well.
Yeah, but receptors not have receptors for beta receptors in the aortic root.
No, have.
Have the beta receptors?
Yes. Brain vessels. What is more important than brain vessels? You went up in the aortic arch.
Coronary arteries.
Coronary arteries. Coronary arteries.
Mm.
Coronary arteries. If the section reaches the coronary artery, the heart will stop. Coronary arteries are more important. That's why we do aortic root replacement. Okay. From where coronary arteries?
تطلع aortic root.
Okay, from where aortic arteries come from? This is a question in the anatomy, by the way. The origin of the coronary arteries.
It's from the coronary sinus?
Yes, above or below the cusp.
Above or below cusp? It's above.
Yes, above, exactly. Exactly, this is a common question, by the way, and very common in recalls and in Fawzia sheet, I think, and in April 2018. Okay, next question, Doctor. Who? Dr. Az?
A 63-year-old.
Okay, go. I'll do the next one.
Okay,
I will go for it.
Dr. Basharat. Yeah, goes in Dr. Az. Okay.
Okay. A 63-year-old man who previously smoked 20 cigarettes a day and has newly diagnosed type 2 diabetes. He presents with rest pain. A diagnostic angiogram demonstrates occlusion of the distal superficial femoral artery, continuing below the knee. He has reasonable posterior tibial artery. He has reasonable posterior tibial artery below this level, which branches to give good runoff to the foot. He has varicose veins. Which of the strategies presented below is most appropriate? A, femoral distal bypass graft using long saphenous vein. B, femoral above knee popliteal bypass graft using polytetrafluoroethylene. Femoral distal bypass graft using polytetrafluoroethylene. And D, femoral distal bypass graft using polytetrafluorine and Miller cuff. And E is above knee amputation. I will go for femoral distal bypass graft using polytetrafluoroethylene and Miller cuff.
Okay, so what is the options here we have?
We have simple polytetrafluoroethylene, or with the vein, or
Okay.
without vein, or amputation.
This patient will go for an anatomical bypass. Okay, this is a young patient,
Yes.
about 63. He has what's called mostly Berger disease. His angiogram showed occlusion, which is long occlusion of this art continued. Diagnosis occlusion the distal femoral artery, continue below the knee. So this is long occlusion. Okay, long occlusion means angioplasty can't be done. So we'll go for bypass. So bypass, I have I have anatomical and extra anatomical. What is the anatomical? Femoral. Femorodistal.
The same course.
Okay. Femorodistal. So I have femoropopliteal, no. Femoropopliteal, no, because here continue below the knee, so the popliteal is occluded. Femorodistal here and femorodistal. Using a varicose vein, and he said here the patient has a varicose vein.
No.
So saphenous vein is damaged. Yes. Saphenous vein is damaged by the varicose vein. So this is also excluded. So I have distal bypass graft by PTFE, polyethylene, and I have one with the PTF with Miller cuff. And he wants here what is the most appropriate. So will be
Miller. with Miller cuff.
Polytetrafluoroethylene
Yes.
with Miller cuff.
Exactly. So we can avoid what is called
Hyperplasia.
new
Intimal
intimal
hyperplasia.
new intimal hyperplasia. Okay. Next, Dr. Az.
A 67-year-old male is diagnosed as having a 7 centimeter infrarenal common aortic aneurysm. What is the likely risk of rupture over the next 5 years? Less than 10%, 20%, 25%, 75%, 35%.
You always have difficult questions with normal range, not to think, just you have to know it. Okay, this is 75%, and this is the normal range. And by the way, no other, I haven't seen before this question or this question. To be honest, I haven't seen it because maybe an old question. But just put in mind, from 5 to 6 is 25, and from 6 to 7 it is 35, and more than 7 it is very dangerous. It's about 75%. Okay, take the other question, please. The next question, Dr. Az, also.
A 54-year-old man presented to the vascular clinic with severe wrist pain and an ulcer on his right foot that is not healing. On examination, he has bilateral absent femoral pulses. Imaging demonstrates a bilateral occlusion of the common iliac arteries that is not suitable for stenting. What is the most appropriate intervention? aorto bifemoral bypass, axillary bifemoral bypass. عندنا واحدة anatomical واحدة extra anatomical, bilateral transfemoral amputation, femoral plus over graft, femoral mobility bypass. I will go for aorto bifemoral bypass, anatomical.
Okay, so you are thinking this is a long segment, so I go for bypass. Okay, and I have two options: anatomical, extra anatomical. This is young patient, fit, so I'll go for anatomical. So I'll go for aorto bifemoral bypass. Exactly. So femoral, I have both femorals are included. Femoral-popliteal is wrong. Bilateral transfemoral amputation not amenable. This is just an occlusion with patent artery. Axillobifemoral, this is extra anatomical and not for this patient. So aorto bifemoral will be the next one. Okay, next one, Dr. Ibrahim.
Okay. 24 years old female referred to acute surgery team as she is noted to have an absent left radial pulse. Apart from some dizziness and lethargy, the patient doesn't have any feature suggestive an acute ischemia limb. Blood test shows the following: sodium 133, potassium 4.1, urea 2.3, creatinine 77, ESR 66. What's the most appropriate diagnosis? Turner syndrome, Takayas arteritis, Kawasaki, coarctation of the aorta, breast carcinoma. Is Takayas arteritis, I think.
Absent left radial.
Salute.
Yes, ESR, elevated
Okay.
ESR.
Okay, this a typical picture for Takayasu arthritis.
Takayas arteritis.
Young female, absent radial pulse, some problem with the arch vessels in the form of dizziness and lethargy, because it's more affecting the proximal part of the artery. Okay, with high ESR, it's apathognomonic or mostly will be Takayasu. Okay, this is a unique scenario with a unique history, and you will just treat 24 female with absent pulse. You will go for Takayasu. By the way, you have, this is one of the questions in the exam, which will just you read absent pulse, you look to the answers, so you will pick up Takayasu or sorry, without completing the question, and you just look for the ESR, you'll find it high. Sometimes he tell you it is high ESR. Okay.
Okay.
Next question, Dr. Ibrahim, one more.
Okay. 60 years old diabetic man present with long-standing plantar ulcer and has clinical evidence of charcoal food. What's the most likely diagnosis? Mixed ulcer, chronic obliterative arterial disease, neuropathic ulcer, squamous cell carcinoma, venous insufficiency. The neuropathic ulcer has long in plantar ulcer, this is what the area, and charcoal food. I think it's
Exactly. This
neuropathic
is
ulcer.
diabetic neuropathy.
Diabetic,
Diabetic neuropathy will cause the neuropathic ulcer and will cause the charcoal food. Exactly. Okay, Dr. Dafir, next two questions, please.
Yes. 65 years old and presents for first time with pain in the back of the skull when he moved while 10 meters. Okay. He is known to have hypertension. What is the most appropriate investigation? Arterial duplex scan, MRI, DSA angiogram, aortic ultrasound, knee X-ray. I goes with the A.
Exactly. MRI angio, DSA angio, aortic ultrasound, no, knee. Okay, the next one, which may be the MRI angio, but to put in your mind in UK, don't go for higher investigation without passing for the primary investigations. Okay.
Yes.
So arterial duplex is the primary before progression to angio. Next question, Dr. Dafr again.
Yes. A 32 years old woman attend the clinical assessment of varicose vein. She has suffering from the varicose vein from the many years and can't trace their development back to when he's suffering from complete tibial fracture. On examination, she has a marked truncal varicose vein with the long tortuous long saphenous vein. What is the most appropriate step? Arrange for venogram, arrange for venous duplex scan, list her for Trendelenburg procedure, list her for injection fume sclerotherapy, list her for multiple avulsion phlebitis. I arrange for the venous duplex scan.
Exactly. So this patient is concerning from varicose vein. I have in history that she had a complex tibial fracture. So maybe the patient have a problem in the venous system. However, these three options list the patient for a procedure before doing duplex scan to make sure that the deep system is patent is a catastrophe. Okay, you are doing ultrasound or duplex scan for any varicose veins for two things. First, to exclude it is secondary and to ensure that the deep system is patent. The second thing is to know the sites of incompetent valves and mark them by ultrasound. So during the operation, you will go for triple ligation and avulsion of these incompetent valves. Okay. So list for any operation. This is so I have these two, and I will never go for an invasive before going to non-invasive investigation. Next one, Dr. Basharat. Next two questions.
A 21-year-old postman notices leg pain after 3 minutes walking during his round. It improves 3 minutes after stopping. Clinically, he is noted to have reduced hair of the lower limbs and his calf muscles appear atrophied. There is weak popliteal pulse, but it is still present when the knee is fully extended. What is the most likely diagnosis? Occlusive arterial disease caused by atherosclerosis, popliteal fossa entrapment, cerebral vascular accident, diabetes mellitus, adductor canal compression syndrome. I will go for the adductor canal compression syndrome.
Exactly. This is a syndrome that happened in a young patient, young man, and he makes some exclusions for you by the other things. So atherosclerosis is not in young, cerebral vascular accident, even not in young, and you have no
Yes,
history of any problem.
Popliteal fossa entrapment also by fully extension.
Yes, yes, this is excluded by fully extension. So I only have this one, the right answer, by exclusion, okay? Adductor canal compression syndrome. Okay. Next question, Dr. Basharat.
Which of the following is not a feature of Charcot foot? Bounding foot pulse in the early phase often occurs in the complete absence of trauma. Erythema of the foot in the early phase, autonomic neuropathy, peripheral neuropathy. I will go for often occurs in the complete absence of trauma.
Okay, exactly. This is the only question you will have about Charcot foot, that it should be a minor trauma or at least minor trauma to have a diagnosis of or a feature of Charcot foot. Okay, you have no other question about Charcot foot, by the way. Till now, till June, till January 2020, no other question about Charcot. Okay, next, Dr. Ez, next two questions.
A 34-year-old man presented with varicose veins, and it is suspected that these are part of the carpal tunnel syndrome. Which of the following is not a characteristic of this condition? Presence of varicose veins, traumatism of a limb, long saphenous vein involvement, port vein stains with clear borders, arteriovenous fistulae. أعتقد اللي هو جينيتيزم of الأم.
long saphenous vein
involvement.
long saphenous vein involvement. Clipped Trewani right present on right side with the leg.
Exactly.
While long saphenous in the
Yes, exactly. We just said it on the start. Klippel-Trenaunay syndrome is a pathology of the Klippel-Trenaunay vein or Klippel nerve, Klippel vein, sorry, which started from the foot and goes up till the gluteal region. And sometimes it is manifest in the newborn child. Okay, you can find this vein on his lateral side, in the lateral aspect of his side. So long saphenous vein involvement is not a feature of Klippel-Trenaunay syndrome. Okay.
Yes.
So why it's come on the right side only?
Sorry.
Why on the right side only? Sorry.
What? Why on the right side?
Why on the right side of the leg of the thigh?
This is the Klippel-Trenaunay vein. It is an aberrant vein present on the right side, on not right side. I'm saying sorry, not the outer side. Lateral side. Lateral side of the leg. You know where is the yani? Okay.
Opposite to the cephalic vein. Yes.
Yeah, this is the legs. This is the saphenous here, and this is the Klippel-Trenaunay up to the gluteus. Okay. Klippel-Trenaunay is a lateral aspect up to the gluteus, up to the gluteus maximus. Klippel-Trenaunay, sorry, long saphenous on the medial aspect of the foot, leg, and thigh up to the saphenous varix. Up to the saphenous varix, the origin of saphenous varix is the femoral. Okay, next question also, Rahman.
Which of the following statements related to coronary artery bypass surgery is true? Late graft stenosis is mainly associated with saphenous vein grafts. It indicates if there is stenosis more than 70% of the right coronary artery. The left atrium is cannulated during the procedure. The CHAD score is used to assess pre-operative risk. Calciplasia is always undertaken at 37 degrees. Late graft stenosis is mainly associated with saphenous vein grafts.
Exactly. Okay. Saphenous vein, we always use the internal mammary artery. Okay, internal mammary artery for the graft, because long saphenous vein is very common stenosis on the long run. Okay, Dr. Ibrahim, next question, please. Next two questions.
33 years old man developed sudden onset abdominal pain and collapse. On examination has tender pulsatile mass in the upper abdomen. He has a blood pressure 90/60 and the pulse rate 105 beats per minute. Which is the following intravenous fluid regimen is the most appropriate while waiting for operative repair? 1 liter of penicillin over 15 minutes, 1 liter of Hartmann solution over 4 hours, 1 liter of glycosphingin over 30 minutes, 1 liter of Hartmann's over 30 minutes, 1 liter of blood over 15 minutes, 1 liter of Hartmann's over 4 hours. Is that right answer?
Exactly. Okay. However, why he asking this question? Because normally in hypovolemic patient, you go with what is called the fluid resuscitation challenge, or fluid resuscitation. Fluid resuscitation, you give Hartmann, 1 liter of Hartmann as fast as possible, and sometimes they say within 15 to 30 minutes. Okay, this is the protocol for any shock, and this is the protocol in part B for treatment to any patient. You will go, this patient is shocked, what will you do? I will go resuscitation fluid challenge. Resuscitation fluid challenge is giving 1 liter of Hartmann solution within 15 to 30 minutes, or sometimes some questions say like as fast or as rapid as possible. Except in this patient, you can't do this. You have to give it within through 4 hours. You don't want to make expansion for the circulation so fast, so not to dislodge any thrombus or any to cause any rupture or hemorrhage through the dissection. Okay, so this is an exception for the resuscitation. Normal resuscitation we do for hypovolemic patients. I just wanted you to understand why he asking this question.
Yes.
Normally
what is Hartmann's solution?
Ringer solution.
Ringer solution.
The same like Ringer solution. Yeah. This is the most close for the normal electrolytes in the normal serum or the human blood. Okay, so this has potassium, calcium, I think magnesium plus sodium.
Lactate.
And lactate, exactly. And Hartmann solution is the most common you give for resuscitation in hypovolemic patients, especially diarrhea, vomiting, bleeding, and so on. Okay, next question, Dr. Dafra also?
Yes.
Okay, next question.
An 83 years old woman is admitted with the left intertrochanteric neck of the femur fracture. On examination, the patient found to have ejection systolic murmur loud in the aortic region. There is no radiation of the murmur to the carotid artery. Her ECG is normal, and it is the most likely lesion. Mitral valve stenosis, aortic valve stenosis, aortic valve sclerosis, tracheal valve stenosis, and the mitral valve breakage. So it is ejection systolic, it is aortic valve sclerosis. Sclerosis because
What?
there's no radiated.
Another cause?
Another cause, it is aortic valve stenosis, but with the radiation. Okay.
Okay. Keep this in mind for part 2. You have a big station in critical care about a patient has an aortic stenosis, young patient, aortic stenosis, and going to do an operation. And he will ask you, what is the causes of aortic stenosis? So you have to start with congenital, and you have to go for young will be rheumatic heart stenosis, and old age you will have to go for sclerosis or calcification. Okay,
Yes.
keep in mind 3 main causes for aortic stenosis: congenital, rheumatic, congenital, rheumatic in young age, and sclerosis or
old age.
calcification in old age. If you just tell the examiner this, so he will be happy with you and you give you a full mark. Okay.
Okay.
Next question.
Okay. A 73-year-old woman collapsed with the sudden onset abdominal pain, and she passed large amount of diarrhea on admission. She is vomiting repeatedly. She has recently been discharged from hospital for a myocardial infarction, but recovered well. What is the most likely cause? Acute superior mesenteric artery embolus, acute inferior mesenteric artery emboli, pancreatitis, infection with the Clostridia difficile myocarditis. So I goes with the acute superior mesenteric artery emboli.
Superior mesenteric artery. Yes, exactly. So the patient has a risk factor of embolic situation
Yes.
because of the myocardial infarction. So this patient should be heparinized or warfarin, give warfarin post-operative or after surgery, after discharge, because they are very susceptible for developing emboli and showering in the body. Okay, so
just a question, small question. How to differentiate it from the inferior?
Sorry, inferior and superior mesenteric.
Yes, how to differentiate it? This, it is not the inferior.
Diarrhea. Diarrhea comes from where?
From the small
intestine.
Yes.
Diarrhea comes from small intestine.
Okay.
And it's most common than the inferior.
Yes.
Okay.
Okay.
The superior mesenteric most common than inferior in getting more thrombi, by the way.
Yes.
Okay.
Okay.
I think it depends on the angle, which is coming from the aorta, favors the embolus to be more common, and it's almost associated with diarrhea. The inferior mesenteric will go for more ischemia in the left colon, and so it is not related to diarrhea.
Yes.
Yes. So next question, Dr. Basharat.
A 52-year-old male attends the stroke unit with dizziness and vertigo while playing tennis. He is known to have hypertension and previous myocardial infarction. He now complains of right arm pain. What is the most likely diagnosis? Posterior circulation infarct, vertebrobasilar aneurysm, dissection of the thoracic aorta, subclavian steal syndrome, left middle cerebral artery infarct. 6 year more.
Subclavian.
Right arm.
I think subclavian is
So
still
it's Dean. With the subclavian steal syndrome.
Subclavian steal syndrome.
Okay. Exactly, subclavian steal syndrome. You know what is subclavian steal syndrome?
No.
Okay. What I
the
make
blood.
now, this is axillary. This is vertebral. Vertebral is a branch from the subclavian artery. Okay. And this is the biggest and first branch, by the way. And we have occlusion or narrowing proximal to the vertebral artery. And I have blood coming from the heart through here. Some go up and some go here. Okay. I have limited blood coming here. I have limited blood coming here. On arm exertion, the arm will take more blood because it's doing an exertion, but he can't take the blood from the heart or from the subclavian because there is limited amount. So it will depend on retrograde blood from the vertebral artery, which will be adducted from the circle of Wills. So the patient will suffer from some sort of dizziness and ischemia because the blood of the brain is coming from the circle of Wills to go to the arm. So in the scenario, it's very common to tell you a young patient or about 50 playing tennis, you know, just playing that. You just imagine like subclavian steal syndrome happens with tennis only. So he just choose tennis. So after playing tennis, he feel like dizzy. And what is the problem? Subclavian steal syndrome. Okay, this is the most common scenario in this. Okay, it's clear?
Not be clear.
Clear? Okay. Next.
A 73-year-old lifelong heavy smoker presents to the vascular clinic with symptoms of foot ulceration and wrist pain. On examination, her foot has area of gangrene and pulses are impalpable. Which of the ankle brachial pressure index measurements shown below is most compatible with this process?
Choose directly.
This is severe. This is 0.3.
Yes.
Exactly. This is critical limb ischemia. Critical limb ischemia will go for 0.3. Okay. Next two question, Dr. Basharat.
A 38-year-old lady is troubled by lymphedema that occurs following a block dissection of the groin for malignant melanoma many years previously. Despite therapy with the compression bandages, she has presented lower leg swelling, impaired her activity of daily life. She has no evidence of recurrent malignancy. Lymphoscintigraphy demonstrate occlusion of the groin lymphatics. However, the distal lymphatic system appears healthy. Which of the following operation could be considered? Demonstrate occlusion of the. This is lymphovenous anastomosis.
Perfect. Clear. I think it's now clear.
Yes.
Yes.
Distal lymphatic system is healthy. He just from all the 4.5 lines from the scenario, you just need lymphatic system appears healthy. So any chronic lymphedema, any chronic lymphatic problem, search for what's called skin healthy or not healthy. This is the keywords. And
Yes.
And is their distal lymphatic system is healthy, patent or not? This is the keywords you will ask about. Okay.
Yes.
Okay.
Okay. Next question.
A 83-year-old lady with a surgical cardiac history is admitted with rest pain and bilateral leg ulcers. Imaging demonstrates bilateral occlusion of both common iliac arteries that are unsuitable for stenting. What is the most appropriate intervention? As the female is 83 years old, both common iliac are unsuitable, so we'll go for axillobifemoral bypass graft.
Because
Old age, she can't
Comorbid.
get a
cardiac.
big surgery like ioto.
So she will go for
Yes, cardiac
extra
patient.
anatomical.
So she will extra anatomical axillobifemoral bypass graft.
Perfect. I think now it is clear how to choose the treatment. Yeah.
Yes.
Yes.
Yeah.
Okay, Dr. Ez.
Yes, a 19-year-old lady presented with recurrent episodes of pain in her hands. She noticed that her symptoms are worse in cold weather. When she gets the pain, Lyme disease. When she gets the pain, she notices that her hands are very pale. They then become dark blue in color. What is the most like Lyme disease?
Perfect. Young female and recurrent
Cold weather.
Okay, so this is a vasospastic disorder. Okay, Dr. Ibrahim. Dr. Ibrahim,
Yeah.
next one.
Okay.
And then Dr. Dafar, last question.
8 years old lady brought to emergency department. My hair care she has been unwell for the last few days. On examination, she has a cold, pulseless leg with fixed mottling below the knee. Double scan show stenosis of profonda femoris and brittle artery with no flow distal to this. What's the most appropriate course of action? Femoral crossover graft, axillofemoral, transfemoral amputation, great stock administration of IV amphotericin. This is transfemoral amputation.
Yes, fixed.
Okay, exactly, above knee amputation or transfemoral amputation. Perfect.
As pulseless leg with fixed mottling.
Fixed mottling. So we are going for amputation. So this is a dead limb. Last question was Dr. Dafar.
Yes, 74 years old lady has a long-standing varicose leg ulcer overlying the medial malleus, which are the clown statement made to the management conditions fault. Pentoxifylline may be sprayed to use ulcer healing. Treatment with the daily low dose fluoxacillin may spread ulcer healing. This is the true one. The multi-layer bandage may provide compression equivalent to the 40 millimeter mercury. Large ulcer may be considered for skin graft. They should not be treated with compression stroke if the ankle brachial pressure index is 0.4. So it is B. Treatment with the daily low dose fluoxacillin may be spread the ulcer healing.
So this is the false answer. This is a false about this. Exactly. Yes. So antibiotics will not speed the ulcer healing because the problem is not infection. Okay, however, thank you. We finished vascular on 2 stations. I'll stop the recording now, please. Thank you.